This is Microbiology, Unit 7, Part E of the lecture, the last and final part of this unit. Hypersensitivity is any immune response against a foreign antigen that is exaggerated beyond the norm. Autoimmune diseases involve the immune system attacking the body's own tissues. Immunodeficiency disease results from failure of the immune system. Our immune responses, or our hypersensitivity responses, are categorized into 4 types. The type 1 immediate hypersensitivity involves the localized or systemic release of inflammatory chemicals in response to the antigen. The response is immediate and develops in seconds. The allergen is the antigen that stimulates the type 1 immediate hypersensitivity reaction, and allergies are the resulting immune response. During sensitization, Th2 releases IL-4 and stimulates the B cells to form plasma cells that produce IgE instead of IgG. This leads to sensitivities with subsequent exposure. There is degranulation when the allergen enters the body and binds IgE. This triggers the release of inflammatory chemicals from the granules and generates the symptoms. The mast cells are distributed throughout the body in connective tissues other than the blood and tend to be found close to body surfaces. Their granules are packed with inflammatory chemicals. Histamine stimulates bronchoconstriction, smooth muscle contraction in the gastrointestinal tract, uterus, and bladder, and capillary dilation. The capillaries become leaky, causing the tissue to become red, swollen, itchy, and painful. The kinins are another chemical promoting inflammation and are released by mast cells. The proteases are enzymes that destroy nearby cells, activating complement and causing more inflammation. Both leukotrienes and prostaglandins are lipid molecules that act as potent inflammatory agents. Basophils contain granules filled with similar inflammatory chemicals to mast cells. Basophils bind IgE and degranulate, increasing inflammation. Mast cell degranulation releases a peptide to stimulate the release of eosinophils from the bone marrow. The eosinophils go to the site of mast cell degranulation and degranulate their own inflammatory chemicals and leukotrienes to increase the severity of the immune response. With so many inflammatory chemicals, an antihistamine alone often does not eliminate symptoms. Hay fever is a localized upper respiratory response to inhaled allergens. This includes nasal discharge, sneezing, itching, and tears. Asthma is also a local reaction where the allergen is small enough to reach the lungs. This results in wheezing, coughing, excess thick mucus, and bronchoconstriction. Anaphylaxis is a systemic allergic reaction. Here, the release of inflammatory mediators exceeds the body's ability to adjust. This includes bronchospasm, increased leaky blood vessels, and swelling of other tissues. The patient can die within minutes due to the drop in blood pressure and impaired breathing from the vessels leaking so quickly and the involvement of the respiratory system. Type 1 hypersensitivity can be diagnosed by injecting a dilute solution of the allergen in the skin and observing for local reaction. Oftentimes it is diagnosed on clinical presentation alone. These are not real pleasant tests for the patient because you are looking to agitate this type of response, and the testing involves actually triggering a smaller amount of immune response in their skin. Prevention relies on identifying the allergen and avoiding it, especially for those with severe cases. Elimination diets can be used by eliminating foods and watching for the allergy to cease. These can be time-consuming and require a significant commitment from the patient. For severe reactions, treatments include antihistamines, corticosteroids, and epinephrine. Antihistamines prevent the release of histamine or its effects. This has limited effectiveness since histamine is only one of the chemical mediators. Corticosteroids counteract the effects of histamine and other mediators. Epinephrine relaxes the smooth muscle and decreases vascular permeability. It is only used as an emergency treatment. There are numerous other products on the market for hay fever type reactions that work through various mechanisms. So when somebody is allergic to bees or certain other things and they're given one of those little bee kits, it's going to be something similar to epinephrine that is in there to stop them from going into anaphylactic shock until emergency care is available for them. Type 2 cytotoxic hypersensitivity occurs when the cells are destroyed by the immune response, complement, and antibody. This reaction occurs with the ABO blood groups. If the recipient has pre-existing antibody to foreign blood antigen, the donated cells are destroyed immediately. They are phagocytized by macrophages, or PMNs, or antibody agglutinates them, and complement does hemolysis, releasing hemoglobin into the blood. This leads to kidney damage, clotting, circulatory failure, fever, coughing, nausea, vomiting, diarrhea, and the liver is overwhelmed. Type 2 reactions also occur with the Rh factor. The Rh antigen is present in 85% of the population. When some fetal red blood cells escape into the mother's blood and the Rh negative mom develops antibody, initially it is IgM too large to cross the placenta. In subsequent pregnancies, the IgG is able to cross. RhoGAM is an anti-Rh serum given at 28 weeks and within 72 hours of delivery to destroy fetal red blood cells and prevent memory cell formation. Without this, subsequent pregnancies result in hemolytic disease of the newborn with jaundice, severe neurological damage, and death. Type 2 reactions may also be drug-induced. Although the molecules of the drugs are too small to be antigens, they can bind haptens and become antigenic, stimulating a humoral response. Immune thrombocytopenic purpura occurs when the antibody and complement bind drugs bound to platelets. The platelets are used, and this destroys the ability of the blood to clot correctly, resulting in purpura seen as purple hemorrhages under the skin. In type 3 immune complex-mediated hypersensitivity, the immune complexes escape phagocytosis and become trapped in the tissue. This causes mast cells to degranulate, resulting in tissue damage. This occurs with hypersensitivity pneumonitis. A sensitized antigen is inhaled into the lungs. This forms immune complexes and activates complement. In glomerular nephritis, the immune complexes deposit in the walls of the glomeruli, causing enhanced cytokine production. The increased intracellular protein impairs blood filtration, leading to kidney failure. With type 4 delayed type cell-mediated hypersensitivity, this results from the inflammation that occurs 12 to 24 hours after exposure. It involves the interaction among the antigen and the APC and the T cells. It requires time for the T cells to migrate and proliferate. Tuberculosis testing is based on this reaction. The tuberculin protein is injected into the skin. There is no response if there is no previous exposure. If the person is sensitive, there will be a reaction with a hard red swelling. It is mediated by the T memory cells in 24 to 72 hours. In contact dermatitis, the urushiol oil in poison ivy or poison oak triggers the CMI, resulting in a rash. Acellular fluid may accumulate as blisters. This reaction is also seen with formaldehyde, some dyes, cosmetics, drugs, metal ions, and latex. This is treated with corticosteroids. Graft rejection occurs when the body attacks tissues or organs that have been transplanted. This is a normal response to a foreign MHC. Autografts are tissues moved to a different location in the same individual, so there is no foreign antigen and no immune response. Isografts are grafts transplanted between two genetically identical individuals or clones, so they have the same MHC with no rejection. Allografts occur between genetically distinct members of the same species. All tissues have a different MHC and give a strong type 4 response, causing graft rejection. These individuals must use immunosuppressive drugs for the rest of their lives. Xenografts are transplants between individuals of different species. These provoke rapid, intense rejection, so they are not commonly used. Some locations in the body are considered privileged sites where grafts are not likely to be rejected. These include the cornea, thymus, testes, and brain. The brain lacks lymph vessels and is impermeable to T cells. Some places have low levels of MHC or have immunosuppressive molecules. Fetuses are not rejected. The early embryo does not express the MHC, and the placenta produces indolamine 2,3 dioxygenase that destroys tryptophan, which T cells cannot synthesize. This prevents T cell division and promotes T cell apoptosis. In graft versus host disease, the donor marrow may regard the patient's cells as foreign and mount an immune response. The level of tissue match required between donor and recipient can vary. The more closely the donor and recipient are related, generally the more similar the MHC. Typically, a 50% match is acceptable for most organs, but the bone marrow needs a very close match. Immunosuppressive drugs have made organ transplants possible. The corticosteroids, such as prednisone, suppress the response of the T cells to the antigen. They inhibit the TC and cytokine production, but are less effective on B cells. Cytotoxic drugs inhibit mitosis and cytokinesis. Lymphocyte proliferation, a key feature of specific immunity, is inhibited. Some examples include cyclophosphamide, azathioprine, methotrexate, mycophenolate, mofetil, brequinar sodium, and leflunomide. The immunophiles are inhibitors of T cell functions. Cyclosporin acts only on activated T cells, so it's less toxic than the nonspecific cytotoxic drugs. Most autoimmune diseases develop spontaneously and at random. Nearly all are more common in females for several reasons. Estrogen stimulates the destruction of tissues by T cells. Maternal cells may colonize the fetus, or fetal cells may cross the placenta and trigger autoimmunity. This is more likely to occur with a daughter. Autoimmunity may result after the recovery from some viral infections. Certain MHC genes are more susceptible and are involved in the regulation of self-reactive T cells. If an infectious agent has an antigen that also cross-reacts to a self-antigen, it may be triggered by a molecular mimicry. Also, there is potential failure of the normal immune system control mechanisms. Single tissue autoimmunity affects just a single organ or tissue. With the blood, a person may have autoantibodies to the leukocytes and be prone to infection. If there are autoantibodies to platelets, the blood does not clot. With autoimmune hemolytic anemia, the person is severely anemic due to autoantibodies to the red blood cells. In type 1 diabetes mellitus, the body produces autoantibodies or T cells against the islets of Langerhans, leading to the inability to produce insulin. With Graves' disease, there is autoantibody that binds and stimulates the receptors on the anterior pituitary, where it produces TSH. This leads to signs of hyperthyroid such as goiter, bug eyes, rapid heart rate, fatigue, weight loss, and increased appetite. Hashimoto's disease is the result of autoantibody to the thyroid gland. In MS, the T cells, the cytotoxic T cells, attach the myelin sheath. It is thought that this may be triggered by viral infection or certain genetic backgrounds. Autoimmunity can also occur as systemic disease, such as with systemic lupus erythematosus, SLE, and RA rheumatoid arthritis. In SLE, there is a loss of control of both the humoral and CMI with autoantibody against numerous antigens in normal organs and tissues and nucleic acids. The immune complexes may deposit in joints or glomeruli. In RA or rheumatoid arthritis, the B cells in the joints produce autoantibody against collagen in the joint surfaces. Certain MHC genes promote susceptibility. Primary immunodeficiency disease is detectable near birth and develops in infants and children. It is the result of genetic or developmental defects. Acquired or secondary immunodeficiency disease develops later in life as a direct consequence of some other recognized cause. Some examples include malnutrition, severe distress, and infectious disease. Chronic granulomatous disease is a primary immunodeficiency disease where the children have recurrent infections characterized by development of large masses of inflammatory cells in the lymph nodes, lung, bone, and skin. The PMNs are unable to kill digested bacteria due to a deficit in polypeptides in NADPH oxidase. In SCIDS, or severe combined immunodeficiency disease, there is failure to develop any lymphoid stem cells, so they produce no B or T cells. This is treated with bone marrow transplant. In DiGeorge anomaly, there is a T cell deficiency as a result of the thymus failing to develop. This is treated with a thymic stem cell transplant. Bruton type A gamma globulinemia is an inherited B cell deficiency. It usually occurs in males, and they are not able to make immunoglobulins, most often IgA. Acquired diseases occur in older individuals who are born with a healthy immune system. AIDS, or acquired immunodeficiency syndrome, is a group of signs and symptoms, such as the presence of several opportunistic or rare infections associated with an HIV-positive test. HIV is a positive single-strand RNA retrovirus with 2 strains. HIV-1 is the more prevalent in the U.S. and Europe, and HIV-2 in West Africa. GP120 is the primary attachment molecule, and the antigenicity varies, making an effective antibody response difficult. GP41 promotes viral fusion of the envelope to the target cell. GP120 attaches to the CD4 marker on the T helper cells, making those the infected cell. GP120 also attaches on macrophages, smooth muscle, nerve, liver, and rarely epithelial cells. One of the things that has worked well for HIV is it's got reverse transcriptase, which is very error-prone, so it produces many antigenic variations, so the immune system becomes overstressed as a result of having to try and start over every time the antigenic variation changes.